First topic would be anemia for the final term. So anemia is a term used to denote condition associated with decreased RBC, hemoglobin, and hematocrit resulting to decreased oxygen delivery to the tissue. We have three definitions of anemia. First, we have the functional, operational, and the conventional. So for the functional definition, this is the decrease in the oxygen carrying capacity of the blood. Operational would be a reduction from the baseline value for the total number of red blood cells, amount of circulating hemoglobin, and RBC mass for a particular patient. And conventional would be a decrease in the RBC, hemoglobin, hematocrit below the established reference value. For the clinical findings of anemia, first is the history of the patient. Okay, physical examination, which will be then performed by the attending physician, the signs and the symptoms of anemia, and the laboratory procedure. The history of the patient includes the diet, a bleeding history, the drug ingestion, occupation, exposure to chemical travel, previous medication, ethnic group, and so on and so forth. For the physical examination, we have the skin that includes pallor. Pallor is reduced oxyhemoglobin in skin and mucous membrane. Jaundice is important assessment of anemia. It may imply evidence of the RBC destruction, and we have also petechia. Petechia or petechiae, these are red spot on the body caused by a minor hemorrhage. And then eyes, mouth, sternal tenderness, lymphadenopathy, the cardiac murmurs, splenomegaly or enlargement of the spleen, enlargement of the liver, plus the vital signs of the patient. There are three general causes of anemia, namely the decreased red cell production. We have also the increased red blood cell destruction and the blood loss. These are the three general causes of anemia. Anemia due to decreased production of RBC includes the iron deficiency anemia or the IDA, in which this is the most common type of anemia, in which this is also yung pinakamadali nating i-treat. Okay, anemia due to chronic inflammation or anemia due to chronic disease. Sideroblastic anemia, we have the megaloblastic anemia, aplastic, thalassemia, anemia due to chronic renal failure, and anemia due to endocrine disorder, and anemia due to marrow infiltration. So these are anemia due to decreased production of the red blood cells. Next is the anemia caused by increased destruction of red blood cells. Under this, we have intracorpuscular and we have also the extracorpuscular abnormality. For intracorpuscular abnormality, we have the membrane defects, wherein the major problem here, of course, would be the membrane itself of the red blood cells. Maybe they lack the protein, the carbohydrates, and the lipids. So this includes the hereditary spherocytosis, elliptocytosis, pyropoikilocytosis, and stomatocytosis. Enzyme deficiency. Under enzyme deficiency, we have G6PD, we have the PKD, and the porphyria. Paroxysmal nocturnal hemoglobinuria or PNH. And lastly, we have the globin abnormality that includes the hemoglobinopathy. For the extracorpuscular abnormalities, we have mechanical. Under mechanical, we have the MAHA and the traumatic cardiac hemolytic anemia. Under MAHA, we have four conditions or diseases associated. We have the TTP or the thrombotic thrombocytopenic purpura. We have the HUS, the IC, disseminated intravascular coagulation, and HELP. HELP means hemolysis, elevated liver, low platelet count. Infection, malaria caused by malaria, Babesia, Bartonella, and Ehrlichia. Chemical and physical agent caused by drugs, toxin, and burns. And we have also the AMA, or the antibody-mediated anemia. Okay, so under that we have the acquired hemolytic anemia due to blood loss, acute post-hemorrhagic anemia, and we have also the chronic post-hemorrhagic anemia. For the laboratory test in assessing anemia, we have your complete blood count. The complete blood count, this is very helpful. This will determine the concentration of the hemoglobin, the numbers of your red blood cells, and the hematocrit. Reticulocyte count is an important tool in assessing anemia. This will signify if our bone marrow is still capable of producing the uh, red blood cells. Next is peripheral smear. So peripheral smear is important in the evaluation of an anemia. So from the peripheral smear, we're able to check on the size, the shape, and the color, plus the inclusion bodies, whether that would be on your red blood cells or in the WBC. So the bone marrow examination, when the cause cannot be determined, so we can have or we can perform the bone marrow examination. Iron studies that include serum ferritin, serum iron, and we have also the TIBC, or the total iron binding capacity. Blood chemistry that includes kidney function test and the liver function test. Urinalysis, check for hemoglobinuria and as well as for hematuria. And then fecalysis would be for the occult blood. And then hematological special test procedure. For example, we have the hemoglobin electrophoresis. Based on the morphological classification of anemia, we have three classifications, and these are the microcytic hypochromic anemia. Okay, microcytic, definitely it means only that the red blood cells are small compared to a normal size, and the concentration of the hemoglobin is decreased. Next would be the macrocytic normochromic anemia, wherein the red blood cells are large or big, greater than 8. And we have the normocytic normochromic type of anemia. Normocytic pertains to the normal size and a normal concentration of hemoglobin. So this is based on the morphology of the morphologic classification of anemia. Under microcytic, we have the SIGA. So sideroblastic anemia, your iron deficiency. We have the globin deficiency and anemia of chronic disease or chronic inflammation. Macrocytic, we have two, the megaloblastic, and then we have the non-megaloblastic. For the normocytic, whether the reticulocyte would be increased. Okay, under increase, ibig sabihin pag tumataas ang ang reticulocyte, meron pong lysis na nangyayari. Okay, that the source would either be intrinsic or either extrinsic. For reticulocyte that would be normal or decreased, maaaring aplastic anemia, maaaring hypercellular or myeloma, myelofibrosis. So these are the topics to be discussed in our first part of the anemia. So let's start with the microcytic hypochromic. So basically, there will be a decrease of all erythrocyte indices. We have the MCV, the mean corpuscular volume. Okay, this pertains to the size of the red blood cells, the MCH and the MCHC. The microcytic hypochromic type of anemia are found in thalassemia and, of course, in the severe iron deficiency. So iron Deficiency. Okay, iron deficiency anemia. This is the most common cause of anemia, and we have three causes. Okay, four causes, three. Okay, so three causes. We have the inadequate intake of iron, increased need of iron, and the chronic blood loss. So this can cause the iron deficiency anemia. This is the most common cause of anemia. Inadequate intake of iron, so 1 milligram of iron is lost every day. Increased need during pregnancy because dalawa na kayong nangangailangan nitong ating um, hemoglobin or ng ating iron, ano? So, our body needs iron to make hemoglobin. So, during pregnancy, we need to double the amount of iron because the body needs iron to make more blood to supply oxygen to the baby. Okay, the chronic blood loss, heavy menstrual, bleeding, GI bleeding, urinary tract with kidney stone, and number 4 would be the iatrogenic cause or iatrogenic anemia is a condition of lowered hematocrit and hemoglobin resulting from a large or frequent removal of blood sample. So, to stop that, stop mo rin yung frequent na pagkuha sa'yo ng sample. Sorry po. So, these are the blood feature of an iron deficiency anemia. Decrease to normal reticulocyte, decreased serum iron, decreased serum ferritin, and an increase of total iron binding capacity. Microcytic hypochromic type of anemia, there would be the presence of anisocytosis or the variation in size and in the variation of the shape. There will be also a decrease in the osmotic fragility test. Okay. So signs and symptoms, okay, medyo makintab, ano, yung kanilang dila. At the bottom, this is what we call as the koilonychia, a condition referred as the spoon-shaped nails associated with iron deficiency. So, medyo kakaiba rin siya. Naka-curve, concave with raised edges, and of course, pica, shortness of breath, and fatigue. So, based on the peripheral blood smear, okay, iron deficiency with microcytosis, hypochromasia, multiple morphologic changes such as the pencil cells, target cells, teardrops or the dark cryocytes, and rare fragments or the presence of the schistocytes. Early iron deficiency may be normocytic with no significant morphologic changes. Sideroblastic anemia is under pa rin ng ating microcytic hypochromic anemia. So, sideroblastic anemia is developed when the incorporation of iron into heme is blocked. Basically, the problem here is there is what we call the blockage in the protoporphyrin pathway in the heme synthesis. So, yun yung nagiging problema natin sa sideroblastic anemia. This is caused by block in the protoporphyrin pathway, resulting in a defective hemoglobin synthesis and an iron overload. So, instead of the healthy red blood cells na napoproduce ng bone marrow, the bone marrow produces what we call the ring sideroblast. And these ring sideroblasts are the hallmark of this sideroblastic anemia. And we have two types of sideroblastic anemia. You have hereditary sideroblastic anemia and you have the acquired sideroblastic anemia. Okay. Primary is genetic, secondary is caused by certain therapeutic drugs, chronic transfusion, alcoholism, and food pads. Diagnostic lab findings is ringed sideroblast in the bone marrow. So if your specimen is from the bone marrow, ang titingnan natin doon would be the presence of the ring sideroblast. If peripheral blood, we have to check or to rule out for the Pappenheimer bodies. Laboratory findings for sideroblastic anemia, we have serum iron increase, ferritin level would be increased also. We have TIBC that would be decreased. The treatment that can be given to patient having sideroblastic anemia is pyridoxine. The pyridoxine will stimulate the heme synthesis. We can have also, kung kaya, would be the bone marrow transplant. Okay, so these are the ring sideroblasts. Okay, these are the ring sideroblasts, the one with blue color, and this could be stained by the Pearl's Prussian blue. Okay, so ito po yung ating ring sideroblast, and that is the hallmark of the sideroblastic anemia. So kapag ang specimen is from the bone marrow, ang dapat na hanapin natin would be the ring sideroblast. Pagka peripheral blood, rule out tayo ng ating Pappenheimer bodies. So for the lead poisoning, lead interfere with iron storage in the mitochondria. Lead damages the activity of enzyme used for heme synthesis. So again, this condition will leading to sideroblastic anemia. Kasi meron din blockage dito during the heme synthesis. So on this picture, we have here the lead lines on the gums of this patient. This one is considered suffering from severe lead poisoning. Okay, so in terms of the peripheral blood smear, ang makikita natin would be the basophilic stippling, which is an inclusion of the red blood cells. Treatment for lead poisoning would be the use of the salts of EDTA. So ano po ba ang meron dun sa salt of EDTA? Isi-chelates niya yung excess na iron that can be passed out through the urine. Porphyria is a rare disease caused by accumulation of porphyrins in the developing red blood cells. Okay, so there will be also an impaired production of the protoporphyrin. Clinical findings for patient having this would be, ano kayang meron dito? Meron pong neurological complication, meron pong impaired production of heme. So porphyrins, okay, these are the main precursor of heme. So heme is essential constituent of hemoglobin. Clinical symptoms, okay, so photosensitivity, there would be abdominal pain, there would be CNS disorder. Next is anemia due to chronic inflammation or anemia of chronic disease. Nowadays, ang tawag na dito would be anemia of chronic disease. So this type of anemia is associated with the systemic diseases such as arthritis, tuberculosis, HIV, malignancies, under that leukemia, lymphoma, and myeloma. So treatment, EPO can correct the anemia of chronic inflammation. So iron also must be administered for anemia due to chronic inflammation. Anemia due to chronic inflammation or anemia of chronic disease is the most common anemia among hospitalized patients. Okay, and one of the hallmark of this condition is the presence of the sideropenia. So what is this sideropenia? Sideropenia means that there is a decreased serum iron but there is an abundant iron stores. Okay, marami pang nakastock na iron pero in terms of the serum iron, yung circulating, there is a decrease of it. So the first main yung pinaka common would be the iron deficiency anemia followed by anemia due to chronic inflammation or anemia due to chronic disease. So thalassemia is chapter 28 on your book, 454, fifth edition of the Bernadette product. So thalassemia is an inherited disorder caused by genetic alteration that reduce or preclude the synthesis of globin chains of hemoglobin tetramer. So, ibig pong sabihin, either ang may problema would be the alpha or the beta globin chains. It was Cooley and Lee in 1925 ang nakadiscover nitong condition because during doon sa kanilang study, meron silang nakitang pasyente na merong anemia, merong may enlargement of the spleen, hepatomegaly, and then the mongoloid phases, ano? So, yun yung nakita nila. And then, eventually, tinawag nila itong thalassemia. Thoracic is a Greek word which means great sea. And we have two categories for thalassemia. Mentioned already would be the alpha thalassemia and we have the beta thalassemia. Predominant in Mediterranean, African, and this is also predominant in Asian ancestry. So again, this was first described by Cooley and Lee in 1925. So ang main problem is the reduction or sometimes wala na talagang alpha or either beta. Okay, ang red blood cells natin, nagwi-weaken po siya. There will be weakening and the destruction of red blood cells. Hindi pa yan. Okay. So, for the types of beta thalassemia, we have the thalassemia minor, we have the beta thalassemia intermediate, and we have the beta thalassemia major. These are the three types or classes of the beta thalassemia. So for the thalassemia minor, the other name would be heterozygous thalassemia, Cooley-Streight, Rayleigh P. Micheli disease. So usually present a mild and asymptomatic anemia. Kaya parang tinawag siyang Cooley-Streight. Cooley-Streight kasi sila yung isa sa mga nakadiscover nitong thalassemia. Intermediate beta thalassemia or thalassemia intermedia, more severe anemia than minor beta thalassemia but do not require the regular transfusion. Okay, so ano nga ba ang meron dito sa mga thalassemia na ito? So there is something to do with the mutation, ano? Mutation po nung ating alpha or either ng beta. Okay, so sa intermedia, occasional transfusion ang kailangan natin. Bakit nga ba? Ano bang meron dito? Okay, so for the thalassemia minor, beta, no, the hemoglobin ranges from 12.4 to 14.2 grams per deciliter para sa lalaki. So, medyo mababa kung pagbabasihan natin yung reference value. Sa female, it has a hemoglobin of 10.8 to 12.8. Sometimes, RBC count is normal or either slightly elevated. So, it is a type of microcytic hypochromic anemia. Okay? Next would be the intermediate or thalassemia intermedia. Okay, so anong meron sa thalassemia intermedia? The hemoglobin is 7 grams per deciliter. Okay. 7 grams per deciliter, occasional transfusion but do not require them on a regular basis. For the thalassemia major, this is also known as homozygous thalassemia, Coolest anemia. We have also the Mediterranean anemia, or this is also known as the target cell anemia. Anong problem? This is the most severe form of thalassemia. Why? Because this is dependent sa blood transfusion. If this would be untreated, yung beta thalassemia major natin, their hemoglobin falls within 3 to 4 grams per deciliter. Their MCV is 50 to 70 lang po. Okay? So the symptoms in the thalassemia major begins to appear between 6 to 24 months of age. Most severe form and transfusion dependent. So, ibig sabihin, lagi pong nangangailangan ng transfusion itong mga merong beta thalassemia major. Next is the alpha thalassemia. So, alpha thalassemia has 4 classification. So, we have the silent carrier, the alpha thalassemia trait, whether that would be homozygous or heterozygous. We have also the hemoglobin H disease, and we have also the hydrops fetalis. So, for the silent carrier deletion of 1 alpha globin gene leaving 3 functional alpha globin genes. So, ibig sabihin kung 4, binawasan ng isa, that would be your silent carrier. Alpha thalassemia trait, ano po ang meron sa alpha thalassemia trait? Asymptomatic, okay? Deletion of 2 alpha globin gene is ang description natin dito. Hemoglobin C will give you a mild to moderate anemia. This is caused by the presence of only 1 gene. Isa na lang po ang natitira dito sa ating hemoglobin H. And finally, the last one would be the hydrops fetalis. In hydrops fetalis, delikado talaga. Kasi wala na po itong alpha chains, ano? So, this is incompatible in life. So, ibig sabihin, maaring tegibels na or mamatay na or patay na, mamatay yung baby doon pa lang sa loob ng sinapupunan. Or, pwede rin pong after giving birth, no, doon sa baby, mamamatay na rin po siya. So, remember that the alpha and the beta globin chains are important because they are the one carries the hemoglobin or the hemoglobin. Next is the hereditary persistence of hemoglobin F, thalassemia with increased levels of fetal hemoglobin. Then we have also the hemoglobin lepor, a rare class of thalassemia caused by crossing over of beta, and we have the delta chain as well. Hemoglobinopathies plus thalassemia is another type of thalassemia in which a combination of 2, hemoglobinopathies plus thalassemia. Hemoglobin C, beta thalassemia with inherited hemoglobin C. This produces severe hemolysis. There would be enlargement of the spleen, minimal or no beta chain production. For hemoglobin E thalassemia, co-inherited of hemoglobin E and beta thalassemia that result to a marked reduction of beta chain production. So the clinical symptoms is similar to beta thalassemia intermedia. Laboratory findings for thalassemia. Okay, so we have the CBC in which hemoglobin and hematocrit would be decreased. RBC count would be increased. There would be a decreased RBC indices and an increase of RDW. RDW is the degree of anisocytosis. For the peripheral smear, we have the microcytic hypochromic type, exhibit anisocytosis, so size and shape would be there. The presence of the nucleated red blood cells, polychromasia, and basophilic stippling. Increased reticulocytes count. This indicates that the bone marrow is responding to a hemolytic process. Bone marrow examination will show hypercellular with extreme erythroid hyperplasia. Decreased osmotic fragility test, supravital stain, okay, and then we have the electrophoresis. We also have the spectrophotometry. This will assess This will assess the difference in the mass of the globin chains. This detects also the single amino acid substitution in the globin chains. And 9, we have the DNA analysis. So through PCR or through SAS or the signal amplification system. And then increase indirect bilirubin. These are some of the laboratory findings for thalassemia. Next is the macrocytic normochromic type of anemia. Okay, so this is on chapter 21, if I'm not mistaken. Okay, so you just browse the erythrocyte disorder. So we have here the megaloblastic anemia, disorder in the DNA synthesis of the red blood cells. Chapter 21, 315. So this one, the megaloblastic anemia, the RBC are very fragile. The lifespan of the red blood cells is shortened and may die in the bone marrow, causing an increased LDH. In megaloblastic anemia, granulocytes are hypersegmented. So yun na yung tinatawag nating uh, hallmark feature of the megaloblastic anemia is the presence of the hypersegmented neutrophils. Platelets are decreased because the main reason is that the bone marrow produces a fewer cell. The maturation of nucleus is delayed relative to that of the cytoplasm, and we have two types of this. We have the pernicious anemia, and we have the folic acid deficiency. So pagka folic acid, that would be more on the nutritional megaloblastic anemia. So if we have the deficiency in the vitamin B12 and in the folate, okay, when either folate or the vitamin B12 is missing, there would be a impaired production of the thymidine nucleotide. This thymidine nucleotide is very important for the DNA synthesis. Kaya kung deficient ng vitamin B12 at saka ng folate, ganun din ang production ng thymidine nucleotide natin. So, walang magsisynthesis ng DNA. Okay. Effects of vitamin B12 and folate. So, vitamin B12, neurologic symptoms. There would be memory loss, numbness, tingling in toes and fingers, impairment of walking by loss of vibratory sense. Causes of megaloblastic anemia, almost the same with the iron deficiency anemia. There would be an adequate intake of the folic acid or either ng ating vitamin B12, ano? Okay, so these are the sources of the folic acid and the vitamin B12. Increased need, okay, so during pregnancy, lactation, and as well as in growth, and then impaired absorption in the intestine. Impaired use to drugs such as anti-epileptic drugs. And lastly, we have the excessive loss during the renal dialysis. For the laboratory findings of megaloblastic anemia, we have complete blood count. So pancytopenia would means that there would be a decrease of the formed element. So this includes the platelet, the RBC, the WBC. Hemoglobin hematocrit is decreased, MCV increase greater than 120 femtoliters. So sobrang laki nung kanilang mga red blood cells. MCH and RDW would be increased and a normal MCHC. Decrease in absolute reticulocyte count. Okay. So we're done with the laboratory findings. Hypersegmented is there. Okay. So for the sequence of development of megaloblastic, number one, since the major problem here would be the decrease in the vitamin levels of your B12 and the folic acid. There would be hypersegmentation of the neutrophils, oval macrocytes in the peripheral blood, and megaloblastosis in bone marrow, and then lastly would be anemia. So that is the sequence of development of megaloblastic anemia. One is decrease in vitamin levels. Two, hypersegmented neutrophils. Three, oval macrocyte. Number number four would be megaloblastosis in the bone marrow, and then lastly would be anemia. Next is the non-megaloblastic anemia. So this anemia is caused by the conditions such as alcoholism and chronic liver disease. So there will be lack of hypersegmented neutrophils, no more oval macrocytes on the peripheral blood smear, and then there would be no megaloblastosis in the bone marrow. So next topic is the normocytic normochromic anemia. Under normocytic, we have the extrinsic hemolytic anemia. Under extrinsic, we have the antibody-mediated, the mechanical, chemical, and physical agent. And lastly would be the infection. Antibody-mediated anemia, we have three classifications. This includes the autoimmune hemolytic anemia, or the IHA, drug-induced immune hemolytic anemia, and we have also the alloimmune hemolytic anemia. For the autoimmune hemolytic anemia, this is characterized by premature RBC destruction caused by autoantibodies that binds to the red blood cell surface. So types of IHA, we have the warm reactive autoimmune hemolytic anemia. So YHA is the most commonly encountered autoimmune hemolytic anemia, and that is positive. DAT is positive, or the direct antiglobulin test is positive for warm reactive autoimmune hemolytic anemia. And cold reactive autoimmune hemolytic anemia, we have the paroxysmal cold hemoglobinuria. Okay, so ito na po yung warm. So again, warm reactive autoimmune hemolytic anemia, or WIHA kung tawagin, would be the most commonly encountered autoimmune hemolytic anemia, and this is responsible for approximately 70% of immune hemolytic cases. So most common, it could either be idiopathic or it could either be secondary. So ibig sabihin may pinanggagalingan, no? Okay, so the next one would be yung CAD naman. CAD, or the cold agglutinin disease, or cold reactive autoimmune hemolytic anemia. Okay, so mediated by antibody with maximum binding capacity at 4 degrees or below 32 degrees. Signs and symptoms, there would be fatigue, there would be pallor, weakness. So, yun po yung sa cold reactive natin. And this CAD, or the cold reactive autoimmune hemolytic, these are actually commonly found also in healthy individuals. Mild anemia, 9 to 12 grams per deciliter of hemoglobin. Okay, pagka medyo severe type, pwede silang ah, maging less than 5 ang kanilang hemoglobin. So the IgM is responsible in here. IgM binds to red blood cells after exposure to a cold temperature. Paroxysmal nocturnal hemoglobinuria. Okay, so this could either also be idiopathic or secondary. So pag secondary, ang PCH daw is associated with syphilis. So ang present naman dito would be the antibody which is known as the Donat Landsteiner. Okay. So caused by an antibody, Donat Landsteiner antibody that is present in the plasma of the patient. So we have here the characteristic of the autoimmune hemolytic anemia, the warm reactive, cold reactive, and the PCH, the type of immunoglobulins that would be present. For warm reactive, we have the IgG, cold reactive would be IgM, and PCH would be IgG also. So complement activation would be variable. Pwedeng hindi, pwedeng ma-activate, pwedeng hindi. But for your cold reactive and paroxysmal cold hemoglobinuria, yes po ang activation. Type of hemolysis for warm reactive would be extravascular. Cold reactive would be either intra or extravascular. For PCH, that would be intravascular. So we have the autoantibody specificity. We have the small anti-I for cold reactive and anti-I na capital, and then anti-P for your PCH. Treatment that can be given to the patient having the warm reactive, corticosteroids and splenectomy. Of course, kapag cold reactive naman, avoidance of cold places. Tapos, we can have the plasmapheresis. Ganun din sa PCH natin. Drug-induced hemolytic anemia is self-limiting but severe, even fatal, following the administration of drugs that can cause immune hemolytic anemia. So what would be the best treatment for the drug-induced? You stop the drugs or the medication that you're taking para hindi na magtuloy-tuloy pa. So what would be then the example of the drugs that can cause this drug-induced immune hemolytic anemia? So we have the penicillin. Okay, we have the stybofen and alpha-methyl dopa. So drug-induced immune hemolytic anemia is a blood disorder that occurs when a medicine triggers the body's defense system to attack its own red blood cells. This causes yung red blood cells natin to break down earlier than normal. Okay, so is the autoimmune hemolytic anemia. Usually occurs in newborn following the transplacental passage of maternal anti-fetal red cell antibody. And we have two causes for this one. We have the erythroblastosis fetalis and we have the isoimmune HDN due to and ABO incompatibility. So, isoimmune HDN due to RH incompatibility or yung tinatawag natin HDN. So, this HDN occurs when the IgG alloantibodies produced by the mother crosses the placenta into the fetal circulation, and then it will bind to the fetal red blood cells that are positive. So this is the first part. We're going to have the second part of the anemia.